So what I'm going to do in about 45 minutes for this first talk is to give you what I think is enough information that if you were sitting the boards and you got a question on CKD anemia, that you would be able to hopefully answer it, to provoke you enough about how to treat this so that you are left with some, perhaps some uncertainty about what one should do. And the reason for provoking you and leaving you with some uncertainty is because, frankly, we don't have all the answers with regards to treatment of CKD anemia. After all, we're not normalizing the hemoglobin. Patients and healthy people walk around with normal hemoglobin, so clearly we don't know enough about it. And third, to give you some insights about where we're going in the field, or where we're going won't be in the boards. That's the way I'm going to structure my presentation. So I'm going to start with a case history. This is a 62-year-old white woman with a 10-year history of CKD from diabetes. She's had slowly worsening kidney function, past medical history of a right CVA stroke, and she comes to see you in the office. She feels great, working, exercising, eating well. And you confirm that, in fact, by talking to her companion who's sitting in the office in your clinic room with her. Lab data shows a BUN of 48, a creatinine of 4.2, an estimated GFR of 18, a hemoglobin of 8.9, a TSAT of 30%, and a ferritin of 282. And really the question, and I'd love you to use your audience response, this little panel that you've already been using, I guess, to answer which one of the following is correct. A, you start this patient on an ESA, darbepoetin, at 40 micrograms per week. B, you empirically treat her with a course of intravenous iron. And C, you check her stool guaiac, and if the stool guaiac is negative, you continue to observe her. Which one do you think is the correct answer for this? So it's a useful question, right? I don't think anybody agreed. 32% thought you start the patient on an ESA. 17% thought that we should treat her with a course of intravenous iron. And 52% thought that you should just leave her alone, right? And the correct answer to this is you check a stool guaiac. And I think this does hint at, in some ways, a controversy, because most of us would say, well, a hemoglobin is 8.9. That's below what is really acceptable for people with CKD based on the guidelines, at least the way most of us understand the guidelines, so you should treat her. In fact, if this was a dialysis patient, we get penalized in the dialysis unit if the hemoglobins fall less than 10% by Medicare. But only 32%, I'm glad only 32% said, well, just leave her alone. What about the treatment with intravenous iron? I can imagine that you probably thought that these iron stores are not reflective, or these iron measures are not reflective of iron stores, because the TSAT of 30% is greater than 20%, and 20% and above is compatible with intact iron stores, at least based on some studies. And a ferritin of 282, where ferritin is an indicator of iron stores, not circulating iron, 282 is fine. In fact, 282 is a little high, perhaps indicative of some inflammation. But based on this, you certainly wouldn't say I would just empirically treat her, because I would argue that you'd want to know whether there was other evidence of iron deficiency or functional iron deficiency, if you will. Is there other evidence of inflammation that makes you think that this ferritin is elevated or in the 282 range because of that inflammation? And so I think B would not be right. And C, I think, is right because she's doing fine. She's wearing her hemoglobin of 8.2 really well. So should one treat? I would argue no. And so I would agree with the 52% who said don't treat her. She's not symptomatic. She's doing fine. And really, the key message in this history is the issue around stroke, the history of stroke. Many people have not picked up the idea that exposure to darbepoetin, or I would imagine ESAs of other type, associated with a higher risk of another stroke if someone's had a stroke already. So if you're a patient with a hemoglobin of 8.9 and who's doing fine, and you increase the risk of stroke in that woman by a threefold factor of 3, I think you'd say, I want to hesitate about treating her. You would work up the anemia, make sure she's not bleeding. And really, there is no evidence that I'm aware of from any of the randomized trials. The treatment of mild anemia is a disease-modifying treatment. If you do treat, in these cases, you might treat because the patient has some symptoms. This is the US FDA ESA label from 2011. It hasn't really been changed that much since then. The FDA label for the drug says, consider initiating ESA treatment only when the hemoglobin level is less than 10. That's the official threshold level, right? So if this was coming in the boards, this would be a reasonable threshold to use. 10 and below, you treat, except if there are reasons why you shouldn't treat. Patient's not symptomatic, patient has a history of stroke, or patient has some other reason not to treat. The KDIGO anemia guidelines from 2012, and they haven't really been updated much because there hasn't been a lot of new data that's come up, sadly, since over the past 8 years, basically says in initiating and maintaining ESA therapy, we recommend balancing the potential benefits of reducing blood transfusions and anemia-related symptoms against the risk of harm in individual patients, e.g., what's the harm in individual patients? Stroke, vascular access loss, and hypertension. And that's a class 1B recommendation. There are probably a handful of recommendations in nephrology that go to the level of 1A or 1B. So this is a 1B recommendation, suggesting that you really need to be thoughtful about who you treat and when you treat. And then they go on to say, we recommend using ESA therapy with great caution, if at all, in CKD patients with active malignancy, in particular when cure is the anticipated outcome, 1B, a history of stroke, 1B, or a history of malignancy, 2C. So if you were doing the boards and you had to answer this question, if you have a patient who has a history of stroke and who's otherwise doing well, you need to be cautious in treating. And a hemoglobin of 8.9, I don't think is justification to treat because of that. I certainly wouldn't treat. It goes on to say, don't maintain the hemoglobin above 11.5, individualize the therapy, and don't get the hemoglobin above 13. So those are all these things. If you remember this is stuff that might come up in the boards because it's pretty non-controversial now, at least given the state of play we have from an evidence standpoint. What should the hemoglobin target be? There's some debate here. KDIGO would say less than 11.5, FDA less than 11. What about the lower number of hemoglobin? KDIGO would say greater than 9, FDA would say greater than 10. And there's some reasons why from some of the trials, and I'll discuss the trials in a minute. Now, if you're coming from Europe, and I imagine there are a few people from Europe in the room, the European best practice guidelines for anemia say the target hemoglobin should be 10 to 12. So, the literature is the same. It's how you interpret these targets. In the US, it's 10 to 11, a narrow target, with the Europeans saying 10 to 12. Now, for the purposes of the boards, and even just to understand where these recommendations come from, I'm going to review with you 3 trials, 3 randomized controlled trials. Each one of these were published in the New England Journal of Medicine. And each one of them, I think, made an important contribution to our understanding of what we should do with these patients. But in aggregate, this data is not enough. I don't think that we have heard the last word on what we should do with regards to treatment. So let's just go over them quickly. If you're not familiar with this trial data, I think it's worth at least paying some attention to it, because nowadays in board exam they will ask you about what a trial showed, so it's important to know what the key messages are. In the normal hematocrit study, which was published in the New England Journal of Medicine in 1998, they tested the hypothesis that patients with normal hemoglobins, a range of 13 to 15, will have better outcomes than patients with a hemoglobin of 9 to 11. Made a lot of sense, right? You have a drug that raises the hemoglobin. People are walking around with a hemoglobin of 13 to 15 without kidney disease, and that seems to be beneficial from an evolutionary standpoint. Why wouldn't you take somebody who has kidney disease with a depressed hemoglobin and normalize it? Makes sense. After all, when people have diabetes, they lose islet cell function, they become insulopenic. What do? We try to normalize the blood glucose. We don't say it's satisfactory to keep a patient at 180 on a blood sugar of 180. We say we want to try and normalize it the best we can, while at the same time reducing side effects. So same with cholesterol and so on and so forth. So it seemed obvious that we would want to normalize. They tested this hypothesis in a randomized trial, 1,233 stable hemodialysis patients who had some history of cardiovascular disease, just like the people we take care of in dialysis. And the primary endpoint, the thing they were looking for, the outcome they were looking for, was would normalization of hemoglobin reduce the risk of death or MI? And these are hard endpoints. Nobody's going to think you're going to fluff or fudge the death endpoint or an MI endpoint. And what they found was, or what they reported, was that in patients where the hemoglobin was normalized, here you see the goal was 42% hematocrit, but the achieved was 39%. That's about 13 grams. The total number of deaths and the total number of non-fatal MIs was higher. And that is pretty surprising, since you would have predicted it in the reverse. So why was that? Is it because you raised the hemoglobin too high? Or is it because these patients were exposed to nearly 3 times as much EPO, 460 units per kilogram? And we've never, ever gotten an answer to that. Is it raising the hemoglobin, or is it exposing patients to a higher EPO dose? And we'll come back to that. Now, this, for those people who have a very keen eye on statistics, will see the relative risk of 1.3, but it goes across a confidence interval that spans 1, suggesting that if you put a p-value to this, it was not significant. But in fact, when they reanalyzed this and after some inquiry about what this meant, the authors published an addendum in the New England Journal saying that in fact, when you look at this data, with all of the patients analyzed, it does reach statistical significance. And that's why in the label, a p-value is provided. We did a study, sort of a mirror image of the normal hematocrit study. And this was in non-dialysis CKD patients. We took 1,432 subjects, 130 centers in the US. All of them were treated with erythropoietin alpha, followed for about 16 months. And we randomized them to a high target hemoglobin of 13.5 versus a low target hemoglobin of 11.3. We got close to 13, close to the lower end of the normal range. And in the lower target, we did get 11.3, which is what we were targeting. And again, to our surprise, the results were very similar to the results from the normal hematocrit trial. If you treated patients and try to normalize their hemoglobin by using high doses of erythropoietin, you had a significantly higher risk of bad things happening. Death and cardiovascular complications, as you can see here, about a 33% risk, which if quantified is about the same risk which was observed in the normal hematocrit trial. And what was driving this risk was death. 65 deaths in the higher arm. That's a 1.5-fold higher risk of death. So this was why everybody got really concerned about normalizing the hemoglobin in both dialysis and non-dialysis patients. A black box was issued, and these new target levels of hemoglobin came, which were much tighter than they were before. And so if you want to know why are we treating patients to subnormal levels of hemoglobin, these two trials essentially nailed this issue. Haven't given us enough information to tell us what should be the ideal hemoglobin, but they have told us what hemoglobin levels, based on the way we treat patients with the doses we treat them, could be harmful. A third trial, which I participated in, published also in the New England Journal of Medicine, called the TREAT study, was a placebo-controlled randomized trial. A placebo trial is taking active treatment like EPO or darbepoetin and comparing it with usual treatment without treatment with an ESA. 4,038 subjects with diabetes, chronic kidney disease, and anemia, and they were randomized roughly in equal proportions. And patients were compared to placebo. So you either normalized or you didn't treat the patients, except if they fell below 9. And very, very, very few people were rescued. The key finding in this study was the following: that for the two composites, cardiovascular and renal, there was no benefit of anemia treatment compared to placebo. Think about that for a second, that there's no disease-modifying benefit of treatment with ESAs on either death or cardiovascular disease, or the renal composite of death or ESRD, when you compare treating to either 9 or normal. And so when you look at that question I gave you, 8.9 isn't that far away from 9. And so 9 is not such a bad place to be, because raising it is not going to benefit these patients, as far as we know, in terms of improving their likelihood of survival or reducing cardiovascular outcomes. The other thing that this study showed was that there was a significantly higher risk of non-fatal and fatal stroke. Patients had more strokes when they were exposed to darbepoetin than they weren't, if they weren't. So there was something going on where exposure to drug and normalization of the hemoglobin, or tried to normalize, was associated with an increased risk of stroke. That was a twofold increase, roughly, and highly statistically significant, although the numbers of patients were not that great that had strokes. But nonetheless, there was a very strong difference. And that's why the KDIGO guidelines caution around treating patients with respect to stroke. But the thing they caution you about is if there's a history of stroke, because in the TREAT study, when you looked at the incidence of stroke by history of stroke, those individuals exposed to DA, which is darbepoetin, had a threefold higher risk of stroke compared to those treated with placebo, 12% versus 4%. So put that in context. If you told your patient that I know you're feeling great, I can't tell you there's any real benefit in terms of reducing cardiovascular outcomes or death or renal outcomes, but I'm going to increase the risk of you having a stroke by threefold, what do you think the decision ought to be? The answer is no, don't treat me, as long as I'm feeling okay. If there's no history of stroke, there is a higher risk, a little bit of a higher risk, but it isn't much higher. It's only twofold higher. This is threefold higher. So here's my algorithm for anemia management. And this is where there's a little bit of uncertainty and controversy, because it's my own guidance. I do this for my own patients. And you can decide whether you, interpreting the evidence and looking at the guidelines, agree with this or not. If I see somebody with a hemoglobin of 11 or less, I look for causes for their anemia in these patients with kidney disease. And usually it sits in one of these three, but usually a combination of these three: iron deficiency, erythropoietin deficiency, and or inflammation. Those are the three things that are usually going on that are causing this patient's anemia. So what I do first is I try to figure out which bucket are they in. Is it likely iron deficiency, likely ESA deficiency, or is it likely to be due to inflammation? So this is that third plank that most people don't think about, which is inflammation as being associated with anemia in our patients. If their ferritin and TSAT is less than 100 and less than 20 respectively, I treat them with oral iron for at least 3 months if they tolerate it. Now, a number of you will say, oral iron doesn't work. I'm going to treat all my patients with IV iron. And by the way, oral iron is associated with lots of side effects, including bloating and constipation, and the patients complaining to me about black stool and so on. And I say all those have reasonable points. The guidelines say at least you should give a trial of iron orally. And I do give it because have you tried to send a patient for infusion therapy? Unless you're doing it in the office, it's challenging to schedule. And it costs the patient more money. And nowadays, I think we should be a little bit more cost conscious. So I try oral iron, and some patients with mild iron deficiency, it works perfectly fine. If it doesn't, I bring them back in 3 months' time, and I send them for a course of IV iron. If I think it's likely ESA deficiency, the iron stores are fine. There's no folate or B12 deficiency. There's not any obvious cause of inflammation. They don't have a failed kidney transplant. They don't have a skin ulcer or something like that. And there's no evidence of occult blood. Blood loss. Then I treat them with a hemoglobin trigger. If their hemoglobin is less than 9, even if they've had a prior stroke or active malignancy, I give them very small doses, because less than 9, substantially less than 9, particularly if they're symptomatic, you want to worry about them. But most patients don't have that. And so you do treat them using the trial data that I shared with you before, and get them started, when their hemoglobin dips below 10, somewhere between 9 and 10. Usually they're tired at that time and they're a little bit more fatigued, and I'll get them up to between 10 and 11. For likely inflammation, I look for what the cause of inflammation are. The albumin low, is the ferritin very high, is the highly sensitive CRP high, and I try to ameliorate their inflammation. Now let's continue the case. This 62-year-old woman, 2 years after initial presentation, now is feeling fatigued with minor tasks, has difficulty getting out of bed. Hemoglobin is still 8.9, but now she's symptomatic. Iron stores are replete. She started on ESA. Her hemoglobin responds and she feels better. 6 months later, she develops an ulcer in her foot. Her hemoglobin starts to drift down despite a gradual 3-fold increase in a darbepoetin dose, which is now 120 micrograms Q weekly. So the question is, which one of the following statements is correct? A, the patient should be treated with a course of IV iron. B, the patient requires a blood transfusion in order to get a hemoglobin up. The most likely cause of her ESA resistant, a diabetic foot ulcer. Don't escalate her ESA dose. Instead, focus on treating a foot ulcer. And D, treat her with an anabolic steroid. Why don't you vote on that? So at least I know you were listening. So everybody's asleep. That's good. I'm glad of that. And that's the correct answer. I didn't hear you there. But that's the correct answer. C. Now, this person has a state of ESA hyporesponsiveness. Hyporesponsiveness. Quickly review that. ESA hyporesponsiveness is otherwise known as ESA resistant, erythropoiesis stimulating agent resistance. And it's really defined as the following: patients who do not achieve the desired hemoglobin concentration despite higher than usual doses of ESAs, or who require increasingly higher ESA doses to maintain a hemoglobin concentration. I'm defining this based on something that Jeff Burns wrote in Up to Date. The problem is that there are many definitions of ESA hyporesponsiveness. And the question is, what is the correct one, right? The most popular one is the K-Doki one. And I would urge you to use this one. I use this one, the K-Doki definition. It's a failure to achieve or maintain target hemoglobin levels at an erythropoietin dose of 450 international units per kilogram per week when administered intravenously, or a little bit lower if it's given subcutaneously. So if a patient is not able to maintain their hemoglobin while receiving 450 milligrams per, 400 units per kilogram per week, so a 60 kilogram person, we're talking about 25,000 units, a week, then that is compatible with a state of ESA hyperresponsiveness. There are many others. There's the KDIGO definition. There's a definition in the UK from Edinburgh. There's a definition from European Practice Guideline, NICE, Indian Nephrology, and so on and so forth. And they're in your syllabus. I don't use any of those. I just use this one definition because I think it's practical and it's American. And that's what most of my colleagues tend to use. The main causes of ESA hyperresponsiveness is iron deficiency. We know that. But the second most important is inflammation. And there are a number of others which you may see from time to time. They're all sort of causes that are used, that you might come across more in exams than in practice. Certainly, ACE inhibitors can cause ESA hyperresponsiveness. They do that through a couple of ways. One is it reduces angiotensin II release of erythropoietin, but also by inhibiting something that inhibiting a compound that activates pluripotent hematopoietic cells. But if you look at all the data published on ACE inhibitors associated ESA hyperresponsiveness, half of them say ACE inhibitors don't do it, and half say that it does. So it's controversy. So most intents and purposes, I would focus on iron deficiency and inflammation. In this paper by Cam Kalantar from University of California, Irvine, he looked at a cohort of 38,000 people, and the most common causes that he found or observed was dialysis catheter, comorbid conditions, malnutrition, and metabolic bone disease, and any other surrogates of low iron stores. So that's what I would be looking for. If I see somebody with ESA hyperresponsiveness, if they have a dialysis catheter, that's causing inflammation. Comorbid states, like, for example, an ulcer in a diabetic, a failed kidney transplant, think about ESA hyperresponsiveness. Now, I'm going to take you back to a slide that is a sort of a pathophysiology slide, but I'm going to use it to make a point. Today, in 2019, the conductor of the orchestra with regards to iron mobilization and iron in general is a compound called hepcidin. Hepcidin is produced in the liver, and basically this conductor, as a conductor of an orchestra, regulates how iron moves from storage areas or from the gut into the body. And hepcidin, as the Cliff Notes version of this, the level of hepcidin is influenced by two major factors: inflammation, and whether you have renal excretion. You can excrete it, so kidney disease. Low hepcidin levels increase mobilization of iron. High hepcidin levels decrease mobilization of iron. And so hepcidin has become a really important compound that you need to know about. And in the future, we're going to have drugs that actually can modulate hepcidin and might actually regulate how iron gets moved around in the body. So hepcidin is a key molecule. And this just shows you this in a cartoon fashion. I'm not going to go into it in more detail than this, but lower hepcidin synthesis in the liver targets the duodenum and spleen and causes increased absorption of iron. Iron also is released by the spleen into the circulation if hepcidin levels are low. And so hepcidin is a master regulator of iron metabolism. And it does it by not, people say, well, it's a switch. It's not really a switch. It results, high hepcidin levels, the higher the hepcidin that's around, the more likely that there's internalization and degradation of ferroportin, which is the gate that allows iron to move around across cell membranes. So hepcidin is an important compound. And I'm not going to share with you too much of this other than saying that you can see what happens in low hepcidin conditions on the left hand of your screen and high hepcidin levels on the right-hand side. And you see that the three cells that it's targeting are the enterocyte in the gut, the hepatocyte in the liver and splenic macrophages, obviously in the spleen, and movement of iron is now regulated, and it depends really on hepcidin levels. But the key issue to also take away is that plasma hepcidin levels are elevated in CKD and ESRD. So you ask the question, why is it that people with kidney disease don't absorb oral iron at all or well? It's because hepcidin levels are high, because hepcidin isn't excreted by the kidneys. So if you were thinking about what types of patients will respond to oral iron, it's going to be the inflamed kidney disease person, not the less inflamed, because inflammation is going to exacerbate this problem with hepcidin. The levels are going to be even higher. And those people who are healthy, walking around, who have reasonable kidney function, who are mildly iron deficient, hepcidin levels are probably not that high, and those patients probably will be able to absorb iron. So in thinking about who you should treat with oral iron, look at the patient and try and get some sort of a fix of how inflamed the patient is and how bad is their GFR. So we talk about this: reduced GFR, iron supplementation, inflammation, and vitamin D deficiency all increase hepcidin, and that is involved in how iron gets moved around the body. So how do I think about ESA hyporesponsiveness? First, you have to diagnose it. I would recommend you use the KDOQI guideline, as we discussed. 450 units per kilogram per week represents the threshold level. Anything higher than that, think about ESA hyporesponsiveness. In that type of patient, avoid repeated escalations in the ESA dose. Identify correctable versus non-correctable causes, and then divide your patients into easily correctable, potentially correctable, and impossible to correct. There's no point wasting your time in people who are impossible to correct. They have hemoglobinopathies and bone marrow disorders. These are people who are going to require specialist input from a hematologist. Easily correctable, you don't need a lecture on that. Potentially correctable, think about functional iron deficiency, and we'll come to that in a second, but that is where our nephrology skills come in figuring out and navigating how we correct these patients. It's in the middle group that you have to make the judgment call: should I treat empirically with iron? Because the lab values are very difficult to interpret, and you have to give iron sort of based on your clinical judgment rather than all the evidence lining up in favor of treatment. Now, I do want to mention to you two different types of iron deficiency. One is absolute iron deficiency, TSAT less than 20%, ferritin less than 100. Interestingly enough, these are our own definitions. If you try and correlate this with body storage iron using Prussian blue staining of bone marrow, about 40% of these people still appear to be iron deficient. But they're not so iron deficient that we should be treating every single person with iron. What we want to do here is say these are accepted guideline-based recommendations of how we define iron deficiency. I think that's fine. Functional iron deficiency or relative iron deficiency is the real thorny thing to deal with, and this is defined by my good friend Ian McDougall, who says in which there is insufficient iron incorporation into erythroid precursors in the face of apparently adequate body iron stores. So we think the iron stores are fine, but the iron is not working. So these people have functional iron deficiency because the iron is sitting in places sequestered, and the body, particularly the marrow, isn't able to get access to that iron. And why is that? It's because there's a block in movement of iron. Now, the last thing I'm going to do in iron is I'm going to just discuss with you a study. This study, I was involved in its conception, and I was one of the authors. It's called the DRIVE study. This study is a small randomized trial that is the only study that has really looked at what to do with patients with functional iron deficiency, and it's defined how we treat patients in the United States with iron. And it's a pity, really, even though I would ordinarily say I'm going to defend this study, even though I was involved in doing it. I'd say it's not enough for us to take not 1 million, but 500,000 dialysis patients and say we're going to treat these patients according to what this study says. Essentially, this study, there was only 134 patients that were randomized. It was a short-term study. Basically, they were randomized to two groups. One group where you treated them with just a higher dose of ESA, and another group where you empirically treated them with iron. And you look to see whether treating these patients who seem to be a little inflamed empirically with iron, despite TSATs and ferritins that didn't really suggest absolute iron deficiency. Did it work? Did it raise the hemoglobin? And the answer was it did. And so in these patients where the ferritin was 761 on average and TSATs were around 19%, they had functional iron deficiency and treatment empirically with iron worked. In the dialysis world, people have taken this to mean that we don't need to worry about ferritins. If the ferritin's 800, still treat. Ferritin's 1200, still treat. And I would say we should not base wholesale practice changes on a study that's only got 130 patients. And I still say that we should be cautious in how much iron patients receive, and be careful about who you treat till we know what the true safety profile is of using iron in these sort of patients. In another paper, which was related to the DRIVE study, we looked at, can we use other indicators in these inflamed patients who are empirically treating with iron, other than iron stores, to predict who would respond? And the answer is no. So we're stuck with these patients, but just treating everybody who looks like they're not responding to ESA, who are hyper-responsive with just a dollop of iron, I think you just need to be, I'm not saying you shouldn't do it, I think you should just be cautious about doing it. Because as you know, in some in vitro studies and other models, treatment with intravenous iron can or has been associated with depressing neutrophil function. And while the evidence is controversial, we need to be cautious that we're not making patients more susceptible to infections, especially since infection is an important cause of mortality in our patients. Where are we going with iron? There are newer iron therapies, and I'm not going to spend a lot of time, but there are these 4 new class of agents that are out there. Intravenous iron for the first 2, ferric citrate, which is an oral form of iron, where it also binds calcium, which also binds phosphorus. And SFP, and I was involved in the development of this drug, where you put iron into the dialysate, and rather than giving patients dialysate that's crystal clear, you basically give them black dialysate because it's filled with iron in it. And it's starting to emerge as an option, although when patients see black dialysate in the dialyzer, they sort of freaks them out a little bit. And so you have to pre-warn them, don't worry, this is not contaminated water that we're giving you. The last thing I'm going to discuss with you, where are we heading? And I think we're heading towards activating endogenous erythropoietin production. Using an oral agent to get the body to produce its own erythropoietin. And you say, how can that be? After all, the kidneys are where erythropoietin is produced, and when you get kidney disease, the kidney dies, and it won't produce erythropoietin. But the interesting thing is that through discoveries that have been made, and looking at the science of this field, if you activate the erythropoietin gene, you can result in erythropoietin synthesis and production, not from the kidneys, but from the liver. You switch on liver production of erythropoietin. So it's a bit like saying, I figured out an agent that allows me to produce insulin from places other than the pancreas. Isn't that pretty neat? And so this is a form of gene regulation, and using factors or agents that stabilize a protein called hypoxia-inducible factor. There are others that are involved in inhibiting an erythropoietin promoter that have not really been tested in clinical trials as yet. But this one, HIF stabilizing agent, this class of agent, otherwise known as prolyl hydroxylase inhibitors, are now being tested actively. And as you know, there was 2 papers in last week's issue of the New England Journal of Medicine from Chinese investigators that demonstrated this agent works. This class of agent works. How does it work? And just to show you this, under normal oxygen conditions, these HIF stabilizers, prolyl, they are not acting on this enzyme called prolyl hydroxylase, and you do not have any EPO gene transcription. So this is under normal circumstances. Prolyl hydroxylase is working. In HIF-stabilized patients, it mimics what happens in hypoxia. That's why they call them hypoxia-inducible factors. These agents inhibit prolyl hydroxylase and activate these HIF stabilizers that then result in EPO, erythropoietin gene transcription. So it's a neat way of activating endogenous production of erythropoietin. A single dose study, this was published in JASN, in healthy controls, you see that plasma EPO levels go up. They go up in anephric hemodialysis patients without kidneys. And in nephric dialysis patients, they go up even more because you still, in addition to the liver, you still get some production of erythropoietin from the kidney. So we now have an agent that can activate the production of endogenous erythropoietin. How cool is that, right? These are phase 2B PHI studies and non-dialysis and stable dialysis patients using a class of agent that's called daprodustat. Just in the interest of disclosure, I work on this program, trying to develop this. And when you randomize patients to different doses, you see that there's a dose-dependent increase in hemoglobin in these patients, whether it's dialysis or non-dialysis. And it does it through an increase in a dose-dependent way in the production of endogenous erythropoietin, measured here, 11.7. You go up in placebo patients, 33.3 with 4 milligrams of daprodustat, going up to 80.2 when you give exposed patients to 10 milligrams. So dose-dependent increase in endogenous erythropoietin levels. These are the papers in the New England Journal of Medicine from July 24th, just a week or so ago. 305 Chinese dialysis patients. You treat them with roxadustat. This is another class of agent within agent within the same class of PHI agents. You see the increase in hemoglobin. What's remarkable is you also see a decrease in hepcidin levels. When you decrease the hepcidin levels, you mobilize iron more. So now you have an agent that might have two ways of acting on this anemia algorithm that I described. And this is in dialysis patients and similarly seen in non-dialysis patients, now published in the New England Journal. So what is the beauty of these agents? Are they safe and what will be their role? As far as we know, they are safe, but trials are still underway, and we haven't heard the last of it. At the current ASN, I predict there will be abstracts and talks on PHI and purporting to their safety. And I think that the answer is we wait and see what the data shows. What is remarkable is that we do get away with not using very high levels, or inducing very high levels of circulating erythropoietin. So we don't use 20,000 units of EPO in a patient, exogenously injected, and we don't get these very peak levels that we see in our dialysis patients or non-dialysis patients. What happens is you give this and you get small increases in circulating erythropoietin. And so if indeed it's not the raising of the hemoglobin that's harmful, but exposing patients to high doses of erythropoietin, hopefully these studies will suggest that not only are they safe, but they may be safer than the existing agents we use, EPO or darbepoetin. And you can see the difference in peak levels, 14 times higher if you give recombinant erythropoietin exogenously versus if you give the PHI. And in aggregate, when you take all the safety data so far in all the phase 2 studies, there doesn't seem to be any obvious side effect that occurs when these patients are exposed to the sort of doses that are being tested in clinical trials. But as I said, the jury's still out on this. We need to wait to see this in publications and scrutinized and approved by the regulatory authorities. So what are the pros and cons? Safer alternative exogenous EPO, oral. Some people say, well, what is that? I don't care whether patients are getting subcutaneous injections or not. Till you're giving yourself a subcutaneous injection, and then you say, yeah, it bothers me, much rather than an oral medication. It does modulate, these HIF stabilizers do modulate other genes and might have a role in iron mobilization through reducing hepcidin levels. There are some concerns, sporadic reports of the one with roxadustat, which is FG20, which is, this is not with roxadustat, but one of its relations from this group of compounds. There was a death from hepatic necrosis, but haven't seen that with roxadustat. There's a potential effect on angiogenesis. There's a potential for increased VEGF levels, which might increase the likelihood of tumors or renal cysts. Haven't seen that so far. So this is very promising. This is very promising indeed. So in conclusion, ESA treatment is a symptom-modifying, not a disease-modifying therapy if you use this exogenous erythropoietin. Target, you can vary it 9 to 11, 10 to 11, but it's going to be in and around that range. In Europe, 10 to 12 if you're using the European best practice guidelines. RCTs demonstrate this increased risk with targeting a higher hemoglobin, targeting with higher doses, normalizing the hemoglobin. ESA hyperresponsiveness, we defined it. It occurs for a variety of reasons, and you need to be vigilant about it, and you need to know that while iron deficiency is the most common cause of it, just throwing iron at everybody is not necessarily the solution. We have to be thoughtful about who we're treating and when we're treating. And particularly if somebody's infected, be cautious about using it, because there is this risk that people have espoused in the past that exposure to iron reduces neutrophil function. There are newer iron therapies, from agents that can be given injectable to iron citrate, which can be as a pill and can also bind phosphorus, to an agent that can be dissolved in the dialysate and you can repair iron deficiency. New forms of ways of getting the erythropoietin level up are emerging. PHI, prolyl hydroxylase inhibitors, HIF stabilizers, are one class of agent. In the phase 2b studies, they seem to be safe. The phase 3 studies from China at least suggest that it is that they work. They work even in patients without kidneys because they cause activation of erythropoietin secretion by the liver. And more on this will emerge in the next few years. So what will anemia therapy look like in the future? My guess is it's going to be without, hopefully without injectable erythropoietin, normalizing the hemoglobin, giving patients an oral drug, and hoping when we have one agent or maybe 1.5 agents, something that treats both erythropoietin deficiency but also mobilizes iron. Thank you very much.